Well, hi, everyone. I think it's almost 3:30. Maybe it is 3:30. It's actually just past 3:30 by my watch. This is a workshop, and it wasn't my idea to have it in an auditorium. Those of you who are on the balcony, you can stay up there if you want, but the problem is that we won't be able to reach you with the roving mic. So if you want to kind of come down, then you'll be able to contribute. If you want to stay up there, then that's up to you. Okay, the first thing to say is that there seems to be two meanings of the word sustainability going around this conference. And it reminds me slightly of the Academy of Management conference last year, which was in Montreal. There were all sorts of workshops on sustainability, and some of them used the definition of sustainability that Dave Pension used yesterday, which was all about climate change and the sustainability of the planet. Others were using sustainability in a much more kind of limited and contained and perhaps conventional way, in that you do a quality improvement initiative and then you want to go back a few years later to see what's left of it, whether it's sustained, whether the impacts are sustained, etc. And it's that second definition that I'm talking about today, not because I don't understand or value what Dave was talking about, but just because we seem to be using this word in two different ways. And maybe we should, get our act together and agree on possibly a different definition for one of those. Anyway, the work I'm not mainly here to present empirical work. I'm here to lead a workshop on how we look at sustainability. It's inherently problematic. Can I just ask you to put your hand in the air if you yourself are involved in a quality improvement initiative? Yeah, right, everybody. Good, okay. Put your hand in the air if you yourself have ever gone back 3 or more years after one of those initiatives and tried to measure whether or not what you did is still happening, or whether it's had any long-term impact. Put your hand in the air. Hardly anybody. Okay, why not? Because people don't tend to fund it, and because it's inherently difficult, but also because we all move on. And you can do a quality improvement initiative, and then 3 years later you're doing something else. You may be married to someone else, you may be working somewhere different, but we work in a very fast-paced environment now. So actually measuring the long-term impact of our quality improvement efforts is something that just doesn't often get done, it doesn't get funded. And I suppose what I'm basing, the idea of this was because someone came to me, a funder came to me about a year ago and said, do you remember that quality improvement initiative that you evaluated 5 years ago, or started to evaluate 7 years ago? We'd like you to come back and tell us what's happened. So that's the background to this. Now, as I said, this is a workshop. She said hitting the firing, and that's not working. I will try this keyboard. Whoa. That's good. Thank you. Okay, so we all have to have a learning outcome. This is the learning outcome for the session. They won't let you send one of these abstracts for a workshop unless there's a learning outcome. So the idea is that to the extent that it's possible, by the end of this session, you'll be able to build sustainability into your plans for quality improvement, taking account of, I've picked 3 key tensions between fidelity and adaptation. Fidelity of the intervention, of the quality improvement initiative, and the need for it to adapt to a changing environment, to new times. Between the hard and soft dimensions of sustainability, which I'll explain, and between static and dynamic aspects of the quality improvement program. So before you get too comfortable, as I said, it's a workshop, So the first thing we want to do is get you into small groups. And don't tell me it's not possible to get into small groups in a large lecture theatre, because it is. I'm going to give you a little bit of an academic bit after you've introduced yourselves in your small groups. I then want you to do a little task in your small groups. We're going to have a plenary discussion and a brief summary. So here's the first thing. If you're going to get into a small group in this slightly inappropriate space, it can't be a very big small group, if you see what I mean. And the best way to do it, I'm told by Professor Lewis Elton, who's an expert on these things, is for 2 people or 3 people to turn round and face the 2 people or 3 people behind them. If you are sitting all on your own, I would encourage you to move, because you're going to feel very lonely. And then the game is to introduce yourselves. Who are we? Why are we here? What exactly are we seeking to sustain? So tell a couple of stories about your quality improvement initiative. What do you want to get out of the session, and what can you contribute? Okay, if you can wind it up. All right, that initial introductions exercise was partly to scare you and into taking responsibility. It's actually quite difficult to identify what it is that needs sustaining, and you know, all those kind of issues. It's quality improvement, as you all know, isn't as tidy as the textbooks and the papers make it, and that's particularly true for the sustainability of quality improvement efforts. I could now get you all to shout out the kind of issues that are coming up in your groups, but I'm not going to do that, because it may get quite chaotic. I don't know you too well. I want now, having pointed you in the direction of your own quality improvement efforts, I want to just talk you through one particular fragment of a quality improvement project which I was leading the evaluation of. And I've chosen, the fragment I've chosen is sexual health services. So we were evaluating a £15 million programme of work. Those of you who heard me talk in Berlin 2 years ago, I think I mentioned, used it as a case example then. One bit of it was sexual health services. And I was approached about a year ago by the funders of that very large whole systems transformation project if I would go back and re-evaluate 3 years after the end of the funding period what had been sustained and what had been spread and all those kind of issues, and to tell the sponsor whether or not they'd actually made a good investment of the 15 million. You can imagine that there's no pressure there, really, is there? Because some of the people delivering that quality improvement effort were my friends. And that was partly because we were building relationships as part of the evaluation, and we continued to those relationships. Some of the people involved had become personal friends. So it was kind of an awkward but very exciting offer. And while we were producing the bid, because this went out to tender, I discovered in the most unlikely place, the Lancet, and the most extraordinary systematic review of the sustainability of health programs. It was extraordinary because the Lancet normally like to publish kind of meta-analysis type systematic reviews of randomized trials, but this Gruen paper actually was a theoretical, systematic review of the theory of sustainability. And I've messed around with it a bit, so it's not fair to say that I'm presenting Gruen et al.'s work, but it's certainly true that I stand on the shoulders of giants in the work that I'm going to present. Now, I bet you all came up with that in your heads or in your groups. Context is pretty key. And then what Gruen et al. Suggests are that there are 3 things that the literature suggests are really important in looking at whether or not something's going to be successfully sustained. The first is the health concern. What's wrong with the population, or what do we think is wrong with them? You know, the epidemiology, the demographics, etc. The second is the program itself, the components of the program and the infrastructure. And the third is what they call the drivers, the different stakeholders in the program and how they're aligned. So those are perhaps the static components of the sustainability equation, but it gets more exciting. It does if I can get my click right. It's not really the hexagons in the diagram that really make or break sustainability efforts, and these guys have moved from a rather static sort of predictors and variance models to a much more dynamic model, which is based on I suppose, complexity theory in the broadest sense. These double-headed arrows. So the top double-headed arrow, the problem definition, how do the stakeholders define the health concern? Not what is the health concern in absolute terms, but how do the stakeholders define it? The second is the quality cycle, which is how does the quality improvement program actually link to the health concern? Is it loosely linked or is it tightly linked? And the third is political economy, which are all those things that tend not to get written up. It's the all the kind of personalities and the Machiavellian power games around the stakeholders and how they relate to and attempt to deliver and influence the program components and its infrastructure. Now, I'm going to talk you through a worked example, and then I'm going to ask you to apply this model. It's a fairly simple model, but you know, you're going to get into trouble when you try and apply it. At least I did. So let me just talk you through this. What we had in South London, or what the people delivering the quality improvement program in sexual health had, was a very deprived, multi-ethnic population. It was an inner city setting with very high population mobility. Something like 30% of the population would move in or out of the area in a year. So you can imagine what kind of mess that makes of your denominator if you're using metrics. People delivering healthcare tended to use rather traditional disease-oriented care models. So, for example, there was genito-urinary medicine with a consultant at the top of the hierarchy, that kind of thing. And as is often the case in the inner city, in deprived inner city areas, the quality of primary care services was very variable. There was a mixture of very high-quality primary care where people had gone to that area out of a professional commitment, and they'd got some funding and set up very good services, and then there was also what has been called the tail of the caterpillar. In terms of the health concern, absolutely dreadful. I think that this area was winning all the league tables in terms of how bad sexual health was. Highest teenage birth rate in Europe, very high sexually transmitted infection HIV rate, very high unmet need. The idea that there was lots of people with sexual health problems who weren't coming forward because the services were so bad, and a high DNA rate, that did not attend for appointments to get the results and the treatment for sexually transmitted diseases. So what did they want to do? They wanted to streamline the service, make things more efficient, look at the patient pathway. They wanted to encourage self-management so that instead of going in there and being cross-questioned by a strict nurse in a white coat and having all your orifices swabbed, you could just sort of use a little machine and get your own chlamydia tests or your own whatever it was and pee in the pot without having to do this sort of humiliating knickers off stuff, which apparently is what puts the patient off. Cultural change in the clinics, the staff, right to the receptionist, all the way up to the consultants, were going to be taught not to be judgmental, to be nice to patients, to encourage them to come back, etc. As far as possible, there was going to be a one-stop shop, and it was going to be painted red and purple inside to encourage teenagers to come, and they were going to build capacity in primary healthcare. So you get the idea. There was a lot of energy, a lot of money. This was £5 million. It's about 5 million euros, I think, the way things are going, but you know what I mean. Okay, what about the stakeholders? Well, these were very interesting. Historical turf wars between two acute hospitals. One didn't speak to the other, and they There was a very vocal third sector with single-issue campaigners, all sorts of people, from the Somalian gay men's rights group to the Afro-Caribbean Christian groups, etc., etc. And there were some rather old-fashioned genitourinary medicine consultants who saw this whole thing as a pyramid of care with themselves at the top. Okay, so those were the what I would call the static bits of the picture, but the dynamic bits were particularly interesting. So if we now move to the double-headed arrows, in terms of problem definition, the genitourinary medicine consultants saw this. They saw the problem in terms of a rising prevalence of sexually transmitted infections and inappropriate referrals from GPs, and they thought the GPs should do all the easy stuff and things should be passed up the line to themselves in their ivory towers when someone had something complex and needing clever tests and specialist knowledge. On the other hand, the staff in the community, the GPs, the nurses, and a lot of the third sector groups saw this much more in terms of complex social determinants of health, women in coercive sexual relationships who couldn't choose who they had sex with or when, and all about issues of autonomy and dignity in disempowered groups. And they saw access to care, for example, in young Asian women and girls, as something much more social. So there were big problems in terms of problem definition, well, not problems so much as discrepancies. In terms of the quality cycle, they used a lot of the quality improvement tools and toolkits that you're all familiar with, and they used them, I think, quite well. They had funding to get people in who understood how to use the various tools and techniques, and they very quickly put in place cycles of audit and feedback which showed that things were improving. For example, improving match between demand and capacity. People were no longer waiting 6 hours to get seen on a Monday morning. They used mystery shoppers who went in there. These were people who didn't actually have anything wrong with them. They were paid to go in and ask for things like pregnancy tests, HIV tests, and they filled out a structured questionnaire, and they showed improvements in what were initially called frosty staff. They engaged primary care. They got the GPs and the pharmacists very keen to undertake sexual health work, and they encouraged supported self-management, but that actually wasn't all that popular. So this idea that people could come in, do their own tests, do their own pregnancy tests, fill out their own referrals for terminations, etc., didn't get off to such a good start. So in general, the quality cycle did quite well. But not perfectly. It never does. What about political economy? This is the stuff which we found very difficult to report. There was a project management group with 82 members because they had to represent all the third sector organisations. There was a lot of fights in that. Right from the beginning, there were disputes about who should chair the group, and then they brought in someone external to chair it, and that worked very well. But there was an awful lot of arguments, a lot of which were based on values. Should we be giving sex-positive messages to 14-year-olds, or should we be saying, listen here, we really don't like the way you're living your life, etc.? And there were big issues around incentive payments, and GPs and pharmacists wanted paying for this extra work. They're very keen to do it, but they said, hang on a minute, we want some item of service. So in summary, what we had here was a pretty tight and effective quality improvement cycle, but importantly, a contested problem definition. There were complex micropolitics and relatively weak long-term business plans. So there was a great sort of energy for engaging primary care, but where was the long-term budget after the end of the funding period to sustain the work? And I think if you look at this, can I do this? Yeah, here. I think I can make a dot there. Yeah. The idea that that there wasn't really the financial levers being built into this system to ensure that things continued. Now, what happened? Well, when we went back, you can see these ticks and crosses in a way because I know the answer. what happened was that some aspects of this quality improvement initiative were very nicely sustained, but there were other things which could be seen to be problematic at the time. And in fact, when we went back, these were indeed the things that returned to sort of bite the quality improvement team. And particularly the lack of long-term business plans was highly problematic. So if we go back to the South London Sexual Health Service now, I am told, and in fact we've sort of done a bit of mystery shopping ourselves, you get a pretty nice reception from the staff. Depending on which day you arrive and which time of day, your waiting time is now lower. There's a lot of things that are pretty good. There is still self-management around, which isn't terribly popular. But there's also aspects of the service which just sort of flopped as soon as the funding period ended. Now, I want you to do the same kind of thing, and I think what you're going to have to do is one worked example. So the one that you guys found the most juicy example in your introductions, I want you to address 8 questions for it. The first is, well, you know, what are the key features of context here? And then the static hexagons. What's the health concern? Who are the stakeholders? How are they aligned? What are the components of the quality improvement programme? But fairly quickly get on to the more dynamic bits, which I think are the more exciting bits and where the trouble gets to start. How closely do the stakeholders agree on what the concern is? How well matched are the components of the quality improvement programme with the health concern? How do the micro-politics and resource stream disputes of the quality improvement programme play out? And finally, overall, where are the weak spots in the dynamic interaction between problem definition, quality cycle, and political economy? Now that's I'm making you jump all over the page there, so I'm going to give you those questions in a list. And I want you to just, you know, put your heads together and just look at one example. And then I want to have time at the end for you to go around with the roving mic and for someone to put their hand up and say, look, this didn't work at all with our example, and tell us why. Because this is sort of work in progress in terms of applying this theory to quality improvement. Okay, you know what you're doing? Yeah? Off you go. I didn't do that deliberately. Okay. So we've got about 20 more minutes. So the task really wasn't to solve the particular problem that you've been discussing, but to try out a model which was developed for a completely different thing. It was a health promotion model, and I've played around with it a bit. So the questions that I want us to bear in mind at a sort of abstract level is, how easy was it to identify the dynamic aspects of the quality improvement programme as opposed to just ticking off the stakeholders and the components? You know, we can all do who are the stakeholders, what are the components of the programme, but then when you start to say, well, how do these play out dynamically over time, it is, I think, more difficult. I'm going to throw it open to you guys in a minute. Secondly, did you find, in your example that you were discussing, potential weak points in that dynamic interplay which suggested problems for sustainability? And for those of you who have been discussing a quality improvement programme that's in the past, were these borne out in practice? So I'm going to now put back these boxes, and then I'm just going to throw it open so you can raise anything you like, really. I think a free and open discussion, because you've been working pretty hard, so I won't kind of make you answer particular questions. Any group got something they want to share? I'm thanking Dougie here for running around with the microphone.
Hello. Another example of local metrics not being available to people involved in projects. So the data all gets shot upwards through the organisation and is really only monitored at board level. So people don't get a sense of what it is that they've achieved.
Okay, that's a really good one. Let's stick with that one. Now, where are we going to put that on my little pin board? Because so we've got a very concrete example here that there's local metrics, and the local metrics are travelling in one direction, which is up to top management, and they're getting discussed at the board, but they're for some reason not being shared. 106, yeah, absolutely. Okay, keep talking about that example. Where are you? Lost you. Why were they not being shared? And you know.
Well, it's interesting. We've got two. We haven't even talked about the project that was an example, but I probably want to hand you over to the person whose example it really is.
Go for it.
I think they are shared on an Excel spreadsheet that only has access to senior management, and I don't think there is a means to inform people, everybody in the trust, of this data monthly.
So there was a weak spot. Very interesting, isn't it? Because I'm drawn to bringing in 7. How do the micro-politics play out? Because it seems to me, and I may be quite wrong because I haven't heard the example, that, you know, who gets access to which data and how that data is shared is actually quite a complex issue in some of these quality improvement projects. And if the data are only going, you know, for example, onto your performance review rather than being discussed over coffee, that you know, the same data may have a completely different impact depending on how they are shared. Interesting example. Because I've got the lights in my eyes, I can't actually see whose hands are up. But Dougie, do you want to keep handing? Yeah.
Hi. We just picked one where I think this is probably quite a typical example, actually, when people who really have a passion and have developed some expertise for delivering a project are working with other hospitals, supporting them. The hospitals are finding that intervention really helpful and actually are passing back positive reinforcement, saying, yes, we like this, we think it's making a difference. But when the chips are down and the financial cuts come, actually they haven't owned the provision of that themselves. And so the transition, making that transition when you've provided your central thing, your baby, if you like, and making the people you're serving it up to take responsibility and ownership for it in such a way that they won't then let it go, seems to be a really big challenge. I'm just going to ask the guy whose issue this is, because he might want to come in on that.
Definitely.
No, you've put it beautifully. Thanks.
Yeah, I mean, one of the quotes that we had from our evaluation of this sexual health project, or actually more widely the Quality Improvement Project, was from one of the Primary Care Trust commissioners, who said that quality improvement is so much about change management, it's so much about engagement, it's so much about getting the energy, and it is not enough about hard-nosed business modelling and creating and putting in place the levers and incentives that are going to... So this is the sort of hard end of building for sustainability. There's a lot of warm feeling inside stuff, but not enough really kind of nailing that down, nailing down the resource streams, because it's actually rather boring compared to all the engagement stuff. Anyone got another example or comment? Someone up the back there. We've got him on a pedometer for this.
Hello, we were discussing sustainability of getting OR personnel, doctors, nurses.
OR meaning operating room.
Operating room, to adhere to checklists. Interesting thing, I'm from Holland and my partners were from Sweden and Singapore, that using checklists was mandated here in the Netherlands, so it was top down. You must, thou shalt do this. So the interesting thing, everybody did, of course, because else your OR, operating room, will be shut down. But now we're facing a sustainability issue, because we see erosion, and there's lots of double-sided arrows going on here.
Go on.
What are my, who's going to penalize me if I'm not doing it at all, or I do it my own way? I just take just 1 out of the 5 issues. Can I get away with it? Who's going to do this? Do we actually agree on, we all agree on the health concern that's really bad to operate the wrong patients, that's not good. But whether a checklist is a solution, I think many of our surgeons would say, I don't need a checklist, I just have to take
now stop there. So what you're saying is, how well matched are the components of the program with the health concern? And then you're telling me that I need another colour to link box 5 and box 6, which is how closely do stakeholders agree on how well matched the components of the QI program are with the health concern? Is that right? We need to make this 3-dimensional. That is
make it a
terrifying.
Sphere,
yeah, absolutely. Anyway, keep talking.
Well, so this apparently seemingly simple issue is full of interesting dynamic components having to do with professionalism, professional pride. I don't need a checklist, and it doesn't matter how many times we say, well, pilots use it. Well, pilots, that's simple, it's just a plane. I'm doing something very complex.
Yeah.
And I have to be very careful, and the heart is in the middle, so I don't need a left-right check. There's long lists of arguments why a checklist is not the solution.
Yeah. So
and the thing is that these arguments will only be told to a junior non-medical professional. So there's also a lot of coverage. There's a lot of how shall we say, political correctness. These things will not be admitted freely.
Okay, so first of all, I need to change the question in box 5 to how closely do stakeholders agree on what the health concern is and what the solution is.
Yes.
And then the micropolitics seem to be playing out that the story that the consultant surgeon tells the junior nurse is different from the story that the consultant surgeon would tell the quality improvement facilitator.
Exactly.
Fascinating. Fascinating. Okay, another example? Yeah.
I come from Norway, and we had a collaborative that had the aim of teaching nursing leaders to lead quality improvement through involving patients. And in 18 months, half the leaders had left the job, and half their leaders again, above them, had also left. And so we had a spread seminar 6 months after the finish of the project, and saw that that they had maintained the results and improved them. And we realized that our focus on changing culture, which was a main focus through the project, may have saved the gains in spite of the leaders opting out or changing jobs or passing on in their careers. And I wonder whether a lot of those points on your board really comes down to culture.
What do you mean by culture?
If we share values, share the way we look at patients, the way we look at services, the way we perceive how to move forward. Once we create processes that align us, we are able to sustain. If we don't, in some way, head in the same direction, sustainability is impossible.
I see what you're saying, and I do agree with you, and it certainly resonates with what we found in this particular QI program, was that the cultural changes, in a way, this is the opposite to what we expected, but the cultural changes, by and large, were sustained, and therefore a lot was sustained. But, on the other hand, without the hard-nosed business modelling, even though people wanted to sustain the changes, they found that they couldn't, because they had perverse incentives to behave the old way. Thank you for that. Any other comments?
Hello. I'd like to just give some feedback on a collaborative project to create an urgent care centre in Swindon, which required, in the UK, which required the bringing together of siloed providers from the acute, primary and community care sectors. And this was a clinically led integrated approach. We allowed and enabled and facilitated our clinical teams to lead the model of clinical care that they felt would be best suited to deliver the optimal urgent care service for local patients. But as a consequence of doing that, I think we paid insufficient attention to the bare bones of the business structure beneath it. Because obviously, in order to develop an integrated approach to that level, it requires a level of integrated financial planning. And integration of culture and behaviours across organisations, which is very, very difficult to achieve. And of course, having come from the NHS and the changing dynamics there, it requires time and consistency in government direction to allow that approach to develop. So we devoted a lot of time to the clinical engagement, the clinical leadership, and didn't really keep pace with the economic drivers to ensure that the project was sustainable.
Very, very interesting. And I would say that this project that we were evaluating, we came up with a very similar conclusion. A lot of very positive stuff, a lot of kind of, you know, nice soft stuff sustained, but actually the economic context was a big thing. And something which, you know, in a way they couldn't control, we couldn't control. But it's something that we really shouldn't be ignoring. I'm going to move on to this question for the last few minutes, because in a way what I've done is I've floated in front of you a model that I've found which was designed for something completely different, which I've adapted, which I'm going to write up in relation to one quality improvement programme. But how useful was it, in all honesty? Did it get you anywhere, or would you, if I just said just talk about sustainability, would that have happened anyway? Any comments on that? The group exercise, no, it's not really the group exercise, it's the model. The group exercise was a requirement because this was a workshop.
I would like to acknowledge that your model and your group work facilitate that we could talk about the difficulties about quality improvement, because one of the things I thought about the other sessions, it's a lot about how good we are working out. This is about the difficulties. That's very good learning for me. Thank you.
But actually, we could have just said this. Just you're allowed to talk about the difficulties, and actually, the model wouldn't have. I mean, certainly, if you look at the slightly theoretical aspects about small group work, it is quite a safe environment, because you as a group can choose whether or not you share anything, and more than half the groups have chosen not to share what they talked about. That's fantastic. That's entirely good, because, but it doesn't mean that you didn't do good work and useful work. Yeah.
I'd just like to back up the fact that the model helped us. I know I was being strict in our group about forcing onto those other three questions.
Which ones? The orange ones?
The orange ones.
Yeah, the orange ones are difficult ones.
Because people will stay in that top group. I would stay in that top group unless somebody challenges me and forces me down into the next piece.
Yeah.
So I think that it's useful in that sense, because otherwise we only do part of the equation, really. Quite often we need some forcing functions to make us go through it.
I like that metaphor almost, a forcing function. When Dougie and I were chatting while you were doing the group work, I came to the suggestion, I don't know whether it's right or not, that whether yellow boxes were the things you can do on your own, by just, if you know the project, you can list it, but the orange boxes are the stuff that you need to deliberate about with other people, either other people who were involved in the project, or a group of people who were not involved with the project, but who are asking you questions about it. And that's what I find quite exciting about this model, is that it requires you to deliberate. And it's a complete pig to write this up, by the way, because the orange boxes are the ones I have to keep going back and asking more people. I don't know whether any other groups found that. Someone's going to comment on something different. Go on.
Excuse me. Yes. Why are you using it just for evaluation? It seems to me that if you use this as a system design perspective from the front end, when you're doing your project in the community, you're going to see some of the dynamic that you're going to have to contend with in order to have a successful project. And then going after the fact, doing the evaluation against what the design. But it seems to me to have some utility at the pre-planning stage or at the planning stage, and not just the retrospective.
Interesting. Haven't we got Martin Marshall in the room? There you go. He funds this sort of work. You put a programme of this kind of work available. No, don't put him on the spot.
No, I'm happy to be put on the spot. No, I think that point is exactly right. I think we as an organisation that fund quality improvement work really struggle with this agenda, and the extent to which you have, first of all, helped us realise that it really is difficult, and secondly, that you have to think in 2 and maybe even 3 dimensions to get it right, is actually very helpful. And I think well, we all know that sustainability is more likely to happen if you do plan it in from the beginning of the project, not think of it as something that you do at the end. So I think that's a very helpful comment.
Great stuff. Thanks, Martin. So we'll look for the call. Is there one more question before we finish? So I don't want to get the reputation.
Yeah, I've got the microphone, so I'll do it.
Go for it, Maureen.
Well, it was just to say, and following on from the query about putting this into the design phase, I would suggest that as part of the quality improvement projects, if there was structured risk assessment of the project, then using some of the concepts you have as your framework, you could feed those into the risk assessment. So the example, for instance, of the consultants using a checklist. So in advance of the project, the thought that you might risk assess it, you may well identify in advance that these issues might come up, and that could start making you think about how you'll deal with that as part of the project. It seems to me quite a useful framework to feed into a risk assessment pre-project.
Interesting suggestion. I'm just immediately applying that to how that might have played out in this particular project. And the problem, I think, is partly that there are some things which you know in your bones, but you are not going to put on a risk assessment, like X's personality doesn't fit with Y's personality, or Z is known to play power games in a particular way. And I think the problem with formalising this right at the beginning and scoring it is the very things that are going to make or break this project are just
I
the
would
ones...
suggest that that's not a proper risk assessment, Trisha. And, you know, if you do the risk assessment properly, you can accommodate these features, I would suggest.
Okay, should we leave it there? I think Maureen and I do like to discuss these things over a beer. Thank you very much for your participation. You've certainly given me lots of interesting ideas to take away in writing up my particular project, and I hope that's been useful. I suspect that next year somebody might come back having applied this in a very different way from how we're applying it, and that would be fun. Thank you very much. Cheers. And thank you, Dougie.